very rightly the issues of inadequate staff and inadequate training, lack of privacy and outdated technologies can definitely affect healthcare and follow-up. And of course, collaborative care model, telehealth for private sector, crisis intervention units, creating healing and safe environment for both patients, doctors and caregivers are very, very pertinent points. And I personally feel, having worked as health secretary for nearly 3 years, that IMA help is quite indispensable. And I take this forum to also say that you did exceptional work during COVID. So thank you. And now I invite the next esteemed panelist, Dr. Hemant Datta, Deputy Director, Regional Institute of Mental Health, Tezpur.
Honorable Chairperson and members of NHRC, Honorable Chair Dr. B.K. Pal, Member Niti Aayog, and Honorable Co-Chair Mrs. P.T. Sudan, Member UPSC. I would like to request to display my PPT. Yeah. So the topic given to me was infrastructural aspects and human resource of the mental health establishment way forward. So I belong to an remote place of Assam. It is Tezpur. So although it is a remote place of Assam, but in case of mental health care services of India, this place is very relevant because it has an oldest lunatic asylum. One of the oldest lunatic asylum was established in Tezpur in the British era. Next. So I would like to cover a few aspects in my presentation. That is, the history of the LGBTMH still holds a space today in today's discussion, because we have learned today that it is very difficult to predict future, because COVID has taught us that we cannot predict what are the infrastructure, what are the human resources we will require in future. But if history, we know our history, then we can up to some extent, we can predict what are the future requirements. So I will also try to, as I belong to the northeastern states, I would also like to state with few challenges specific to northeastern states, and the adequate use of upcoming technologies, and the vision plan of the next 15 years, that is the LGBS model. Next. So these are the few pictures which are taken in around 1980s. The institute was established, the lunatic asylum was established in the British era in Tezpur in 1876. It was governed by at that time by the jail manual, and the patients of the asylums were in a very bad shape at that point. Next. So there was the patients were at that time were meaningfully utilized at this phase. They were used in various cultivations, paddy, sugarcane, vegetables, dairy products produced by the inmates. Next, please. So these are a few pictures of the old buildings and the facilities available. The very right upward picture is the oldest OCT machine we had, and the chair which is showing that it was used for the hydrotherapy. That is the water was poured over the patients to heal the mental illnesses at that time. A few old abandoned buildings we have at present. Next. So these are the intermediate phases for a few photographs. Next. So these are the isolated cells of at that time, a few hospital wards. These are the next. These are the laundry and kitchen setups at that time. Next. So these are the timelines of the LGBTMH, which is an institute under Government of India now. So it was established in 1876. In 1995, Honorable Supreme Court of India ordered transfer from the Government of Assam to Government of India. In 99, it was taken over from the Government of Assam by the NEC under Ministry of Donier. In 2007, it was transferred to Ministry of Health and Family Welfare, Northeastern Division, and in 2010, it was transferred to the Ministry of Health and Family Welfare, Mental Health Division. In the last 10 years, that is from 2012 to 2018, the institute has seen its major transition, mainly in the infrastructural and the human resource aspects. Next. So three basic changes that has been seen in this institute. First is infrastructure, I have already shown to you. Then next is human resource aspect, At the asylum phase, there was mainly the supervision was the main component at that time. We had warder, then we had keepers, we had dhobi, kind of posts were present at that point. Then intermediate phase comes, then where a few medical posts are allowed to the institute, it is medical superintendent. And now it is a modern phase where academic posts are allowed to the are granted to the institute. It's functional. I have already said that it has traveled from asylum to super specialty care. And policy it was initially it was custodial care to the now it is open hospital setup focusing on the rights of the mentally ill person. Next. This is the current stage. A few photographs of the institute, which has shown the state of art infrastructure at the institute have at present. Next. So this is a few photographs of the present time indoor. Next. 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 So the need of integrated infrastructure and facilities. What should it contain at present time? We feel that first thing is that in an institute should have some important infrastructures like comprehensive rehabilitation center. It should contain. First is it should have psychiatrists, counselors, psychiatric social workers, clinical psychologists, occupational therapists, physiotherapists, special educators, orthopedician, pediatrician, ENT specialist for diagnosis and training to make the patients optimally functional and relocation and rehabilitation of the recovered patient. The rights of the mentally ill persons to be at the prime importance in these infrastructures. Then we need some previous slide. Yeah. So today, the relevance of super specialty services come there, and infrastructure should contain the services, super specialty services. Then technology-oriented services should always it should have. My previous speakers have already stated the importance of telemanas, then telemedicine, WhatsApp video calling, message reminders, helpline, etc. Up-to-date infrastructure should contain. We need to have collaboration with the NGOs and up-to-date facilities and machineries for research opportunities, and community clinics, wellness hub, and satellite clinics we should have. Next. These are the specific challenges specific to northeastern states. Although we have some positive aspects, like abandon rates are less in the northeastern states because it has a strong social support system, and traditional healing system works as a parallel system in northeastern states. So although we have some few challenges like cultural and socio-economic factors, then mixture of the tribal and ethnic and linguistic communications. We have some infrastructure and geographical barriers. Substance abuse is a great concern nowadays, and armed conflicts and violence is another important aspect we need to consider. Next. So this is just the data of showing the last 5 years of the patients attending the LGBRMH. In the last 5 years, we have attended around 5 lakhs of patients, and we had informal interview we have done with a few patients of the northeastern states and asked what are the difficulties they face, and they mainly revealed that the accessibility to the institute is the main issue. So we have the infrastructures, but accessibility to the institute we have to think about. Next. So this is the spoke and hub model of the LGBRMH. Now we are working as a hub for the 8 northeastern states, which will provide teaching, research, and expertise needs of these northeastern states. Now we have started 50% reservation of all the postgraduate seats or of these northeastern states. Next. So next. So types of manpower we require at various levels. As it is, we know that psychiatry and the mental health care is still labor-intensive work. We cannot rely on machines to assess the human minds. So at the various levels, we can utilize the manpower, like end user level, the patient care level. We can have the self-help groups, the patients who are having lived-in experiences, and training of the family members for coping strategies and identification of the early symptoms we can do. At village level, we can already utilize the existing resources of government like ASHA workers, Anganwadi workers, panchayats, local clubs, NGOs, volunteer workers, etc. In PHC and CHC levels, we need to have training of the medical officers. Already the digital academy is in operational. Then other supportive health workers we need to train. In medical colleges, train psychiatrists, postgraduate training, consultation license cases we need to address. In tertiary care and center of excellences, then we need super specialty services and training of this, monitoring of these levels, and monitoring of government scheme at all levels. Next, what are the human resources of future needs? We feel that correctional home requires full-time psychiatrists and counselors. Educational institute requires full-time counselors. incorporation of the importance of mental hygiene in school and colleges syllabus. In the industrial sector, still handling labor force requires mental health professionals. Undergraduate medical training in psychiatry needs to be more structured. Increase in number of the postgraduate seats, as my previous speakers have already emphasized on that. Then we need to introduce of target-specific short-term courses after post-graduation, and collaboration and training scopes with state-of-art institution is very important at this stage. Next. So we can increase the human resources by strengthening the mental health education and reduce stigma. Then establish mental health training centers. We have to incentivize the mental health careers. We need to promote the multidisciplinary collaboration and mentorship programs. Public-private partnership is very important at this stage, because it is not possible for to target the all needs of the mental health care in the country with only the government manpower force. So we have to support research and innovation, creative supportive work. Then we need to improve the retention strategies, because we have seen that people join their jobs but they leave their jobs due to some difficulties they face. So we need to study what are the issues they face, and then we can at least retain them in their services. So we need to expand the telepsychiatry and e-health service initiatives. Next. So these are the mental health services. Innovative techniques now are in picture. So we need to utilize at the most these innovative techniques. Telepsychiatry, we all know. Mobile mental health camps already have been seen. Online cognitive behavioral therapy, peer support program, virtual reality therapies, then digital therapeutics, that cognitive training exercises through digital mode, then collaboration care models with the primary care physicians, then text message innovative techniques like follow-up reminders, self-help materials, etc. can be delivered. Next. So telemental health services already my previous speakers has emphasized. Next, the two issues in delivering service in the telemode we have experienced. First is the need of human touch and interaction in psychological assessment to understand the complexity of mind is still we feel it is required. Then medicine availability in peripheral areas and its delivery issues are still problematic. We can give the advice, we can give the medicines through telemedicine services, but people are not getting it there in the peripheral villages and centers. So internet connectivity and digital awareness is still inadequate in periphery. So without addressing these issues, I think it will be difficult to achieve the goal of those telemode services. Next. So scientific approach to the stigma reduction is very important. We already have discussion in how to decrease the stigma reduction. Next. So we often forget about caregivers. We need some infrastructures for caregivers, because they are the most who faces the emotional distress, physical health deterioration, financial strain, social isolation, legal issues. So what are to be considered? Separate residential facilities for attendance in hospitals as they require long stay. Then dedicated facilities for regular counseling and training about coping strategies, and dedicated legal cell for their help. It is the need of the hour. So a few pictures in the right hand side have been implemented in our hospital. It is a patient sofa cum bed, because we had felt that patients can stay can utilize the bed of the hospital, but it is very difficult to stay for attendance with the patient, because they do not have separate beds. So for this, the sofa cum bed we are giving to the attendants. This is the shed we had to make during the COVID period to accommodate, because there was a social distancing policy was adopted. So people used to stay in the hospital outdoors for a long time. For these caregivers, we need to make this shed. And this is the DLSA counter, District Legal Service Assessment Legal Service counter we have. Next. So issue of homeless mentally ill, very important. In the last 5 years, we had approx 100 homeless mentally ill. Most of them have already been reintegrated. And while a few issues we have now finding it difficult in discharge. First thing is not able to trace family members, not able to reveal proper address. Family members are not willing to accept, and then economically unstable to lead an independent life. Next. So a few initiatives have taken by us in association with a few NGOs. The Sadra Foundation in the southern states is already there. They have helped us for reintegration of our homeless mentally ill patients. Next. So only the we should not focus only on the placement of the mentally ill patient in the that halfway homes or shelter homes. We need to utilize their optimal capacities. These are the few pictures and few materials that have been prepared by the recovered mentally ill patients. So it shows they are very productive and their potential can be used fullest. So these recovered mentally ill patients can be there should be some provisions so that they can be engaged in the various industries like agriculture or any other industries, so that they can utilize their potential. Next. Yeah. So it is the now we are we are aware about the artificial intelligence and AI chatbots. So this can be utilized in the mental health care. So AI chatbots, which are 24/7 access, they can be used for early detection and prediction by analyzing the data. Then data monitoring analysis by wearable biofeedback machines, then reducing stigma because people can talk the AI chatbots freely. So these technologies should be used in current scenarios. Next. So this is the vision plan of LGBRMH for the next 15 years. It has already been approved by the ministry. It has 3 phases. First is phase of expansion. Next is phase of consolidation, and third phase of excellence. We are at the first phase. Next. So these are the 10 centers we have proposed, which will target the specific areas like child and adolescent mental health, addiction medicines, Ayush, digital mental health informatics, integrated family well-being, psychotherapy and counseling, neuroscience, rehabilitation science, community mental health care. So we have thought that conversion of the disciplines, instead of working in silos, then people in these centers can come in from various disciplines and work as per their expertise and interest. Then there will be scientific study of the traditional healing methods, because we cannot omit them. It is very important to know the traditional healing methods. It will give that diverse platform for working with the stalwarts, and courses in the line of the NEP with multi-level exit will be designed as per requirement in these centers. Next. So the take-home message is approach beyond hospital boundaries, regular training and capacity building of human resources, strengthening of the support groups, caregivers, local and self-help groups, awareness and stigma reduction, use of artificial intelligence and technology to make mental health care more easily accessible, and optimum implementation of the mental health legislation and monitoring of the implementation of government schemes. We feel it is required. Next. Thank you.
So, thank you, Dr. Datta, for pointing out the need for integrated infrastructure, especially keeping in mind the challenges of Northeast, which are so unique, and of course the need to have private sector, civil society organizations, and collaborative healthcare model. And you've been part of the Digital Academy when we first set it up. So thanks for that great work also. Now I